We should start recording. Yes. So in the continuation of our lectures, our sessions on the obesity, and a very good response by the audience who are participating well. And we are continuing our third session. And today again, there will be two speakers with us. And before proceeding for the other things, first of all, I shall like to invite Dr. K.K. Parikh sir, our moral booster, our godfather, and always inspiring us for continuing these CMEs for the benefit of all the physicians. Dr. Parikh sir, will you like to say a few words?
Thank you, dear Prakash, for very kind words. And good afternoon to everyone. It's really a great privilege to welcome all the delegates attending today's certificate course program, and especially our President, Dr. Girish Mathur, and Dean ICP, Dr. Jyoti Gupta, Dr. Jyoti Paul, sorry. डॉक्टर ज्योति गुप्ता भी आज अटेंड कर रहे हैं मेरे ख्याल से, वो है ना. हाँ,
it will be difficult for him to join.
But still he is attending. That's very good. And Dr. Prakash Keswani, the course director for certificate courses. I must appreciate and extend my sincere thanks to our President and Dean ICP for their great vision and efforts for disseminating the knowledge to everyone, even to the last corner of country. A physician who is situated in the last corner of the country, and which fulfills the aim of our association API, the dissemination knowledge to every physician. I also welcome our learned speakers of today's certificate course program. Very dynamic and young Dr. Rajeev Kasliwal, who will be speaking on obesity as an endocrine disease, and Dr. G.D. Ramchandani, a great diabetologist of great repute, who will be speaking on obesity in adolescent and childhood, which is a very important topic because obesity in childhood is the most important, and we have to make them aware for the obesity. So I hope these scientific updates on different topics will be of great use in updating the knowledge of everyone who are attending this program. I thank Dr. Prakash Keswani and the organizing team for inviting me and making me part of this very important program. Thank you very much. Jai API.
Thank you, sir. Thank you, sir, for your kind words. Your blessings always keep us high.
Thank you, dear.
Dr. Girish Mathur, sir, our dynamic President API, a strong force behind us, always keeps us upright and always inspiring for doing new things. Dr. Girish Mathur, sir, who motivated us to start this program on the obesity, as obesity has come out as an important disease for diabetics and as well as for non-diabetics. Dr. Girish Mathur, sir, I will request you to say a few words to our participants.
Thank you, Prakash ji. Honorable Dr. K.K. Parikh, sir, past President API and mentor and source of inspiration for many of us. Dr. Prakash Keswani, Project Director, ICP Certificate Course on Obesity. The esteemed speakers of this afternoon, Dr. Rajeev Kasliwal and Dr. G.D. Ramchandani. I compliment Dean Dr. Jyotirmay Paul, although he is not able to join today, for taking this initiative to start these important certificate courses on the platform of ICP. Dr. Prakash Keswani deserves special appreciation and compliments for designing the modules of this certificate course so meticulously, covering all aspects of obesity and its management. This certificate course on obesity is getting overwhelming response, and we are getting excellent feedback from all the participants. I congratulate again Dr. Keswani for all his efforts and hard work. I'm sure all the delegates will be benefited immensely by this certificate course. My sincere thanks to Dr. Keswani for giving me this opportunity to join this event. Thank you so much.
Thank you, sir. Thank you, sir. This is all because of your inspiration only, sir. Thanks a lot, sir. Sir, in continuation of the previous lectures on the obesity, previously we have learned about obesity is disbalance between the calorie intake and expenditure. Now again, we have two very brilliant speakers with us. Dr. Rajeev Kasliwal, who is the associate professor and head of the endocrinology in the Mahatma Gandhi Medical College, Jaipur. He will be giving his talk that giving a new side for the pathogenesis of obesity, that obesity is again a endocrine disease. And the second speaker is Dr. G.D. Ramchandani, a brilliant and outstanding diabetologist working a very high quality work on the type 1 diabetics. He will be giving his talk on the obesity in childhood and adolescence. And without wasting time, I will invite Dr. Rajeev Kasliwal, who is our first speaker, to start his deliberation. Dr. Rajeev, you start, please.
Thank you, sir. Kind introduction. So should I start sharing the slides?
Yes.
Okay, fine. So very good afternoon to everyone, and many thanks to Dr. K.
Video cam your microphone is unmuted.
Sir, am I audible? Sir?
Yes.
Audible?
Yes.
Sir, please, all others mute yourself. All others except Rajeev. Please mute yourself.
Thank you everyone for giving me this opportunity on speaking of such an important topic, though slightly theoretical, but we need to understand about the pathophysiology of obesity before we try to understand about the treatment options available to us. So I think this data has already been being discussed maybe in previous few slides and presentations, that we are looking at an epidemic of obesity. And I think almost by 2025, 15% of adult populations are going to suffer from it. And this is more and more becoming a worrisome factor in pediatric and childhood age, which Dr. G.D. Ramchandani is going to speak about it. Why it is important to identify, treat, and manage obesity, because of its linkage to various non-communicable disease which we have. And there is n number of complications which an obesity can bring on the table. It includes various cardiovascular disorders, diabetes, NASH, various orthopedic problems, osteoarthritis, spine problems, as well as increased incidence of malignancies. Now, obesity is a very complex topic. Still, we are trying to decode it. On one side, obesity results from various untreated endocrine disorders, like I think one of the previous talk we have discussed is like hypothyroidism, hypercortisolism, growth hormone deficiency, hypogonadism. All of them can lead to obesity. At the same time, obesity per se can lead to dysregulation of various endocrine organs and the various hormonal functions, and lead to various hormonal disorders like PCOD. Now, in between these two, obesity per se itself is now being considered as an endocrine disease, because the pathophysiology that involves the developed obesity results from dysregulation of various hormones, which are being secreted either by GI tract or by pancreas or by liver. There is some sort of disbalance in these hormones, and which ultimately leads to imbalance between energy deposition versus energy expenditure, and leads to development of obesity. So obesity per se is also now being considered as an endocrine disorder. So what we know that obesity resulting from various hormonal disorders is called as secondary obesity, while obesity of primary obesity is a diagnosis of exclusion, which results from no underlying disease. And what happens in is this obesity? In obesity, there is an excessive deposition of lipids in adipose tissue, adipocytes, and which leads to mitochondrial dysfunction, which lead to endoplasmic reticular stress, and ultimately this leads to a change in the gene expression profile of adipocytes, and which ultimately leads to deranged hormonal milieu in adipose tissue, which is responsible for various complications that we see associated with obesity. Now, so obesity, as you just mentioned, sir, is the consequences of positive energy balance, results from increased energy intake and decreased energy expenditure. So somehow in obesity, there is a dissociation between energy intake and energy expenditure. And even when the patient is having energy sufficient state, the energy deposition keep on going and ultimately becomes pathological. This happens because of the failure of body's homeostatic mechanisms to match the energy intake and expenditure, and that happens at multiple levels. The brain is the most common site where all these regulations happens, and to be precise, it is the hypothalamus which is responsible for control of energy intake and energy expenditure. So and at the center of obesity is the development of obesity is the appetite regulation, or what we say appetite dysregulation. It is a very complex phenomena. How do that appetite get regulated? There are definitely, it is the brain that plays a very important role to activate the satiety at the right time. So there are two different kind of neuronal setups that are there in the hypothalamus. One that stimulates the appetite and another one that decreases the appetite. The neurotransmitter that are responsible for stimulation of appetite are neuropeptide Y, MCU, that is melanocyte cortisol hormone, and then agotylated peptide, orexin, then endocannabinoids. All of these neurotransmitters stimulate the appetite, while alpha melanocyte stimulating hormone, CART, GLP-1 and serotonin, these neurotransmitters decreases the appetite. And whenever there is a balance in between these two kind of neurotransmitter in hypothalamus, we develop obesity. And these setup of neurotransmitters or expression of neurotransmitters get in turn being regulated by various other things like peptides or the gut hormones that are being secreted by GI cells, by gut microbiota, by hormones like leptins, insulin, by metabolite like glucose and ketones. So they are these appetite regulating hormones of the brain are under constant regulation of various systems in turn. So coming first to the adipose tissue that act as an endocrine center. In fact, it is the hormones or the substances that being secreted by adipose tissues are called as adipocytokines. They may act as an distant organ in the endocrine fashion, or they may act locally also in paracrine or autocrine fashion. So there are various hormones that are being secreted by adipose tissue, and important ones are the leptin, resistin, angiotensinogen, visfatin, and adiponectin, etc. And there are other multiple kind of substances that are being secreted by like cytokines, like extracellular matrix proteins, the complement factors, enzymes, acute phase response. All of these are responsible for either development of obesity or the various pathological conditions that are being related to development of obesity in an individual. Coming to the leptin, which is probably considered as one of the most common hormone that is being responsible for development of obesity. So the word comes from lactose, that means thin. It's a 167 amino acid peptide and encoded by OB gene basically, and it is secreted by adipocyte. It crosses the blood-brain barrier and binds to presynaptic GABAergic neuron of the hypothalamus and control the appetite and energy expenditure. So what happens to leptin? Leptin basically inhibits the orexogenic or neuropeptide Y or agouti-related peptide expressing neuron within the hypothalamus. It stimulates the anorexogenic POMC expressing neurons within the hypothalamic arcuate nucleus. So basically, leptin's role is to suppress the appetite. It does so by stimulating the anorexogenic stimulus and by suppressing the orexogenic stimulus. And that is why so this is just a diagrammatic representation of same, like leptin act on the POMC, which is an anti or what is anorexogenic center, and it inhibits the orexogenic center, that is neuropeptide Y or agouti related peptide, and which in turn leads to satiety and stopping of meal intake ultimately. So that is how the leptin works, helps in controlling the weight. Now, so that is why, because and because of this reason, during fasting, during low calorie dieting, during uncontrolled type 2, type 1 DM, where we want to conserve the energy, leptin levels decline. While and this decreased leptin level stimulate the hunger, like that what happens in fasting, like in low calorie dieting, while decreases the energy expenditure and ultimately restores the fat stores, and ultimately the it as the fat stores goes up, the leptin level also increases to the baseline. So that is how the normal physiological regulation happens through the leptin hormone. And ultimately what happens in obesity, and there are two kind of obesity, types of obesity. In obesity, normally what we are expecting, that leptin should be low in obesity, but in most of the cases of diet induced obesity, leptin levels have been found to be high. And the reason that has been that has been proposed and given is that these individuals develop some kind of leptin resistance. Leptin is not able to reach the blood, or not able to cross the blood-brain barrier, not able to exert its effects on hypothalamus, or do not able to produce the anorexic action, and that is why these leads to. So it's a kind of a leptin resistance that happens in obesity. Now, basically leptin, whatever in fact and as the obesity goes up, as the leptin goes up, one point of time leptin develops actually, or trying itself might attenuate the downstream leptin action. So it is a kind of a functional ceiling that happens for leptin action, and that is why in type 2 obesity, where or diet induced obesity, we generally see a higher leptin level, and that is because the leptin functions are simply not happening. So, and at the same time, leptin hormone is a very important hormone. It connects the metabolic status with reproductive axis. We will discuss these changes in the reproductive axis that happens into obesity, but it is the leptin that is a link between the metabolic status and the reproductive axis, like HPG axis, like thyroid axis, growth hormone axis, or adrenal axis. Now, another important hormone in terms of weight management is actually insulin. Whenever it and the role of insulin is to reduce the food intake and the body weight gain, and it acts by suppressing the orexogenic neurons in the arcuate nucleus, like neuropeptide by Y or agouti-related peptide, and it stimulates the at the same time it also have a pessimistic action in terms of synthesis and secretion of leptin. So and ultimately also so insulin resistance, if because insulin causes suppression of energy intake, so insulin resistance also contribute to the development of obesity. So again, the obesity and insulin have a bi-directional relationship. Obesity leads to insulin resistance, and insulin resistance actually, because of its action on the brain and in the hypothalamus, can lead to development of obesity. Adiponectin, I think most of us already know this. Adiponectin is another hormone secreted by adipose tissue, and it is considered to be a good hormone, responsible for various, a lower level of adiponectin in obesity is associated with insulin resistance, dyslipidemia, atherosclerosis in human being, and if we can lose the weight, the adiponectin levels increases again. And at the same time, adiponectin has a various or plethora of anti-tumor effect. It suppresses the leptin-induced tumor proliferation. It retards the aggressiveness of the tumors and their metastatic potential. And that is why high adiponectin level have been found to be associated with decreased risk of breast cancer, colorectal cancer, and endometrial cancer. Now, there are other hormones secreted by adipose tissue that also plays an important role, like omentin. Again, omentin is basically it's a kind of a bad hormone which has been secreted in adipose tissue. There is too much of fat deposition and leads to it leads to various complications that are being seen with obesity. So adipose tissue that act as an to summarize the adipose tissue as an endocrine organ. There are two kinds of obesity: type 2 obesity with leptin resistance. We will have a higher leptin level, and type 1 obesity with congenital leptin deficiency. There is low level of leptin. Adiponectin, and there in obesity, the adiponectin level decreases, camerin level increases, omentin level decreases. So good hormones like adiponectin and omentin decreases, and the camerin retinol binding protein, angiotensin 2, plasminogen PAI, plasminogen activator inhibitor, all of these detrimental substances level rises during with obesity. Now coming to the another important organ, which is GI tract, that is responsible for again control of weight, and especially the short-term control, which is in terms of food intake and food intake behavior. That is initiation of meal intake and termination of meal intake is in direct control of gut hormones. And we have two kind of gut hormones. One is orexigenic hormones, another one is anti-orexigenic hormones. The only orexigenic hormone that is there in the body is ghrelin, that is being secreted by stomach or the GI tract. And anti-orexigenic hormone, there are multiples: cholecystokinin, pancreatic polypeptide, oxyntomodulin, and the more, I think the commonest or the most heard discussed one is GLP-1. So something about cholecystokinin, it's basically a hormone that decreases the food intake, and if they are dose dependently, it rises within the 15 minutes of meal initiation, and ultimately and this is being secreted by duodenum and jejunum. So in obesity, the post meal rise, which should be there in CCK, is attenuated, so individuals keeps on eating and ultimately leads to unchecked weight gain. Something about then ghrelin, again produced by stomach, and it is the only orexigenic gut hormones. It binds to GH secretagogue receptors that are being expressed in neuropeptide Y and ogoty-related peptide neurons, which are responsible for appetite stimulation. So through these receptors, through these neurons, ghrelin leads to stimulation of food intake behavior and ultimately leads to weight gain. Pancreatic polypeptide hormone, again, it is being secreted by pancreas, colon, and rectum. And again, the function is to reduction in food intake and increase in energy expenditure. In obesity conditions, the secretions, the secretion of this hormone get disturbed or decreased, and that is why lead to unchecked weight loss. GLP-1, I think most of us already know about it. It is being released from small intestine and colonic L cell. It is anorexogenic hormones, reduces the gastric emptying, suppresses the gastric acid secretion. And in obesity, what happens leads to satiety sensation acting through the central nervous system. In obese individuals, they have a delayed postprandial release of GLP-1. And as well as the levels are also less in obese patient. And that is one of the reasons why these obese individuals have they keep on eating and leads to inappropriate weight gain. And even the various bariatric surgeries, GI surgeries, have shown that one of the mechanism by which they lead to weight loss is more secretion of GLP or the more exaggerated GLP response in these patients after bariatric surgery. Again, oxyntomodulin is the hormone which is responsible, again leads to increased satiety, reduces the food intake, and the release is proportional to the meal calorie content, and again secreted by stomach oxygenating cell. and the function is to maintain the weight and reduction in the weight. So in again obese individuals, and leads to inappropriate weight gain. So if we summarize the control of energy status, then there are two kind of long-term controls which we have. One is leptin and insulin, which are responsible for long-term weight maintenance, and then short-term control of energy status is mediated through predominantly by gut hormones, cholecystokinin, pancreatic peptide Y. Impact of obesity on endocrine system. So obesity, as I said, one of the key link between obesity and the hormonal function, various endocrine functions, is the leptin, and leptin level affects various pituitary axis like and we will discuss them one by one, like obesity and androgens. So in obesity, the androgen levels are low, testosterone levels are low, both total as well as free testosterone levels are less in obese individuals. And there is both kind of secondary hypogonadotrophic, secondary hypogonadism, as well as primary hypogonadism. Both have been described. And whenever obesity is associated with obstructive sleep apnea, it predisposes to male obesity and secondary hypogonadism syndrome, MOSH, MOSH syndrome, through reduction in luteinizing hormone pulse amplitude and reduce mean level of LH and testosterone. So obesity compounded by OSA is very commonly associated with hypogonadism, secondary hypogonadism. Now there is a chances of there's some element of primary hypogonadism also happens in obesity because of the deposition of pro-inflammatory cytokines in the testis and macrophages, which leads to destruction of leading cell. And actually this is a vicious cycle, because hypogonadism per se is going to lead the increased fat deposition in adipose tissue, and which again is going to contribute or perpetuate this cycle. So what is this called as hypogonadal obesity cycle, where the obesity leads to hypogonadism and obesity leads to further hypogonadism. At the same time, increased adipose tissue leads to increased activity of aromatase enzyme, which is responsible for conversion of testosterone to estradiol. Again this excessive hyperestradiolism, hyperestrogenic state leads to various complications in men. Especially it can lead to, because the feedback inhibition is through estrogen even in men, and that is why it can lead to decreased GnRH secretion, and again contributing to the hypogonadism. Now coming to the women, in females, obesity leads to increased androgen levels, increased free androgen levels, and which ultimately responsible for diseases like PCOD in these patients. At the same time, obesity leads to decreased SHBG, that is sex hormone binding globulin. So free androgens are more available in these patients, and that is why they lead to more androgenic side effects. Coming to the estrogen and obesity, again, because the higher is the amount of adipose tissue, more is going to be the aromatase activity, and that is leads to hyperestrogenic state. And this hyperestrogenic stage is responsible for predisposition to various estrogen dependent malignancies like breast cancer and C endometrium. So obesity can predispose these to malignancies through causing hyperestrogenic state. Coming to the thyroids, in obesity, we know that TSH levels slightly go up even within the normal range. Also, they are on the higher side, and as the weight goes up, the set point for TRH and TSH goes up. So these patients generally have higher TSH value and actually have low free T4 because of the increased deiodinase activity in adipose tissue, which leads to compensatory conversion of T4 to T3 just to increase the energy expenditure. So these patients with obesity have higher TSH and low free T4, which may sometimes may be mistakenly taken as an hypogonadism. And these changes are reversible after bariatric surgery, or by good amount of weight loss. You can lead to normal again leads to various detrimental effects. Direct, which some therapies has also been tried to block this local activation of cortisol to cortisol, which may lead to various side effects associated with obesity. So coming to the last but not least, the obesity and growth hormone. Again, obesity leads to decrease in growth hormone level because of the decrease in the growth hormone level because of the, again, by suppression from the pituitary, because of the hyperinsulinemic state. Because obesity is a condition which leads to insulin secretion from peripheral, suppresses the GH secretion from pituitary. However, at the same time, it tries to maintain the sensitivity of the GH in the peripheral tissue. So most of the time, the IGF-1 levels remains normal in these patients. So these are the changes which is being caused by obesity in growth hormone levels or and IGF-1 levels in obese individuals. And whenever we do cause weight loss by any mechanism, whether it's by surgery or by dietary intervention or lifestyle intervention, these changes are reversible. So to conclude, the obesity leads to significant change in hormonal milieu of a person, which might be reversible on weight loss, whether it is a hypothalamic pituitary thyroid axis, HPG, hypothalamic pituitary gonadal axis, or the growth hormone axis, or hypothalamic pituitary adrenal axis. All these axes gets impacted by the obesity. And then obesity itself in origin is a hormonal disorder resulting from dysregulation of various appetite regulating hormones secreted by adipose tissue or by gut, and by understanding continuous or making attempt at least in understanding these dysregulation, and that is thereby targeting these dysregulation of this dysregulation, then I think we can find much more effective, safe anti-obesity treatment if we can decode this whole gamut of changes that is being seen in obesity patients. Thank you. And I will.
Thank you, Dr. Rajeev, for very informative talk. Have you completed?
Yes, sir.
Yes, sir. So thank you, Dr. Rajeev, for your informative talk. And you have given a very deep insight about the pathogenesis of the obesity. And it is very much clear that it is not simply the excess calorie intake, but is caused by and is promoted by various hormonal disbalances, which include so many hormones, as you suggested, that leptins, insulin, then cholecystokinin, and so many other oxyntomodulin. And again, this obesity leads to a number of hormonal disturbances, and there may be a vicious cycle of obesity leading to the hypogonadism, and hypogonadism again promoting the obesity. Thank you, Dr. Rajeev. You have done a wonderful job, and thanks from the organizers for your cooperation and your help for continuing this program. And dear friends, till this time we have been seeing we have been hearing the various lectures which were about the pathogenesis and development of the obesity and various hormonal disbalances. Now we will move towards the other clinical aspects of the obesity. And for this, today we have another speaker, Dr. G.D. Ramchandani, who will be giving his talk on the obesity in the adolescence and childhood. And in the next sessions, we will be dealing with the obesity and the diabetes, obesity and the cardiovascular diseases, obesity and the obstructive sleep apnea. And this whole of the module will be in the 16 lectures. Now we move towards our next talk, Dr. G.D. Ramchandani, who will be giving talk on the obesity in the adolescence and childhood. He is a brilliant speaker and is a renowned diabetologist. Dr. G.D. Ramchandani, you start please your deliberation.
Okay. So slides are visible, sir?
Yes, sir. Visible and audible.
Okay. First of all, I would like to thank Dr. Prakash Keswani. And at the outset, I would like to thank our patron of this ICP certificate course of obesity, Dr. K.K. Parikh sir, who was the past president of APA and past dean of ICP, and the dynamic national president of APA, Dr. Girish Mathur, and the very academician and very dynamic dean of ICP, Dr. Jyotirmay Paul, and of course, the dedicated course director, Dr. Prakash Keswani, for giving me this opportunity to deliver this talk and allotting me the topic of very important in present recent era, that is obesity in children and adolescent, because I think it is a new epidemic of the developing as well as the developed world, and it is a serious health hazard. I can say it is a serious health hazard of entire globally, and especially in Southeast Asian and Indian subcontinent. And I also congratulate Dr. Rajeev Kasliwal for delivering a wonderful lecture, and one of the most difficult topic and delivered in a very simplified way, that is obesity, various hormones and how they are doing, creating the problem in obesity, and how obesity is creating the problem in the hormonal changes. So I would like to thank and congratulate to Dr. Kasliwal also. So obesity in childhood and adolescence, this is the topic which was allotted me by Dr. Prakash Keswani, and all know that obesity is a burden in developed as well as developing countries, and it is a significant public health problem, or is a new epidemic in last decade. Obesity is a complex condition that interweaves biological, developmental, environmental, behavioral, and genetic factor. And the most common cause of obesity throughout the childhood and adolescence is an inequity in energy balance, that is excess calorie intake without appropriate calorie expenditure. Of course, adiposity rebound is also an important factor, but the most common cause is excess calorie intake without appropriate calorie expenditure. I say that this childhood obesity is a ticking time bomb. In last decade, the obesity suddenly increase in childhood and adolescent age group. I am not going to detail about, previously already shared by all the speakers about the various consequences of the obesity, especially in adult, and I'm not going in detail about the numbers, because the numbers are very not good. As we know that worldwide obesity has already nearly tripled in last 50 years, and 39% of adults age 18 years and over were overweight in 2016, and 13% were obese. But while in children, when we are discussing about the child and adolescent age group, 39 million children under the age of 5 years were overweight or obese, and over 340 million children and adolescents age 5 to 19 years were overweight or obese in the 2016. Just see the burden of disease, because obesity is a disease nowadays, and just see the burden of disease and ultimately leading to various complications in the later age. Then these are the National Health and Nutrition Examination Survey, which was done in 1918 to 2006, that overweight and obesity prevalence tripled in 6 to 19-year-old and doubled in 2 to 5-year-old. That is for children aged 2 to 5 years, prevalence increased from 5 to 12.5. Age 6 to 11 year, prevalence increased from 6.5 to 17%, and from age 12 to 19 years, prevalence increased from 5 to 17%. So just imagine, just see the this prevalence increase almost double to triple in just last 30 to 50 years. Another survey, that is National Family Health Survey, which was conducted in the prevalence of obesity among the children and adolescents between 5 to 19 years, has increased significantly, and this was conducted in the last 3 years back. And the reports of this survey, that the prevalence of obesity among the children and adolescents has increased from 9.8 in 2005 to and 6 to 11% in 2019. Just in 4 or 5 years, is increased by 2 to 3%. Similarly, the prevalence of obesity higher among the urban children and adolescents as compared to counterparts, rural counterparts. And the prevalence of obesity is higher among the girls as compared to boys. And children and adolescents from the household with higher socioeconomic status are more likely to obese. And obesity is more prevalent in children and adolescents in the southern part and western states of India as compared to northern and eastern. They are the Indian data of 2019 and 20. Now come to the contributing factors. Obesity has a multidimensional factors which are responsible for the children and adolescent obesity. They are from individual factors, socio-economic factors, and community factors. In individual factors, they start from the intrauterine environment. It's not the just after the age of 10 or 15 or 20. It starts from the intrauterine environment and ethnicity, genetics. The most important contributing factor is physical inactivity. Second is the dietary imbalance. Even the sleep disturbance is also very important. Parental factors and family environment is also key factor in the obesity. Other socio-economic factors like employment, individual education, household income. Community factors is also equally important, that is schools, because nowadays school is the main contributing factor in the obesity prevalence, increase of prevalence because of the lot of factors in the schools and coachings and hostels, and they are taking high calorie food and not doing physical activity. They are also one of the very important contributing factors. And this is the vicious cycle which we are seeing in, I think, every physician and every doctor is facing, or even every family. We are seeing this factor in our city, Kota, in last 15 to 20 years. After the coaching, the students are coming at the age of 15 and 16 years and staying here for 2 to 3 years and taking high fatty food and high calorie diet and without any physical activity, all time studying, and have more viewing the video games and computers, getting mildly obese. And after that mild obesity, they are unable to have brisk walking and climbing stairs and get high this environment, this high calorie environment and Coca-Cola environment or high fast food environment and stressful situation, getting more weight gain and moderately obese child, and ultimately unable to do exercise because of the pain, and finally have a severe obese child and getting the more complications. So this is a vicious cycle in which that ultimately these children are facing in day-to-day practice. Etiology we all discussed in previous slides, previous topics also. The majority do not have a pathological cause. Mostly it is a exogenous or constitutional. Other causes are already discussed by Dr. S.K. Sharma in the previous lecture. And this etiological causes is discussed by Dr. Rajeev Kasliwal about the leptin, ghrelin, adiponectin. They are the hormones that influences the appetite, satiety, and fat distribution. I'm not going in detail because already Dr. Kasliwal has clarified this pathophysiology of this obesity. Now, how to assess the obesity? Is already in adult obesity is discussed by Dr. Keswani, Dr. Rakesh Sahai, Dr. S.K. Sharma, Dr. Anupam Prakash about that. Body mass index is the most commonly used measure of overall adiposity in clinical setting. Its validity is in measuring adiposity is less well established in children, elderly people, and those who are more muscular. So in children, there are little bit different criteria there. Waist hip circumference ratio, that is a surrogate measures in intra-abdominal or central obesity, predicts long-term disease risk in both man and women independent of BMI. Waist circumference is recommended as the most practical tool to assess abdominal fat or central obesity. This waist circumference, this waist hip ratio are more used in adult, not in the children and adolescent. Definition by WHO, as we all know, that is BMI, as per BMI, which is calculated by weight in kilogram divided by height in meters squared. It is divided, obesity is classified. If it is less than 18.5, it is underweight. Between 18.5 to 12.49, it is normal weight. Above 25 to 29.9, it is overweight. and about 30 is obese. This is for adult. This classification is for adult and international classification, that is global classification. While in, as per WHO suggested, have lower cutoff of Asian Indian due to higher risk of cardiovascular disease and to type 2 diabetes at the lower BMI levels. And as per WHO, Indian definition of obesity is overweight about 23 and obese about 25 kilograms per meter square, but this is for adult. Now come to the obesity in children. Body mass index after the age of 2 years. It is calculated after the age of 2 years. Below the age of 2 years, we don't calculate the BMI. We are measuring the weight for length. So after the age of 2 years, this BMI, as per Indian Academy of Pediatric Guideline 2015 charts derived from the backtracking of adult body mass index, Indian cutoff of overweight is 23 kilogram per meter square and obesity is 27 kilogram per meter square. That is for children and adolescents. Extreme obesity is BMI is more than 120% of the 95th percentile or more than 35 kilogram per meter square. There are some limitations of BMI like ethnic differences in the proportion of the body fat at the same BMI and lower reliability in pubertal age. Children and adolescents are more likely to be classified as obese than those who are the same age but pre-pubertal age group. Erroneous diagnosis of obesity in short and muscular individuals. So below 2 years of age, the weight for the height or weight for the length is tool for the obesity. Till 2 years of age, if it is more than 97.7th percentile, such as the obesity. So these are the criteria in children. And the diagnosis, unlike in adults, Z scores and percentiles are used to represent BMI in children and vary with the age and sex in the child. BMI score cutoff point are more than 1, more than 2, and more than 3 are recommended by the WHO to define at risk of overweight and obesity and respectively. In terms of percentile, overweight is applied when BMI is more than 85th percentile to less than 95th percentile, and obesity is when BMI is more than 95th percentile. So there is still confusion about the Z score and BMI. Therefore, to prevent this inaccuracies and easier understanding, it is recommended that BMI Z score is in children should be used in research purpose, whereas BMI percentile are best used in the clinical setting. Waist circumference, which is more commonly used in the adult obese patient, waist circumference is recommended as the most practical tool to assess the abdominal fat or central obesity, because excess abdominal fat assessed by the measurement of waist circumference is independently associated with a higher risk of metabolic syndrome like diabetes and cardiovascular disease. Higher the waist circumference, higher the cardiovascular and mortality risk. This is the HOPE study which was published. As you just see there, the incidence of cardiovascular death, MI, and all-cause death were high in a person which is a high waist circumference, that is more than 103 centimeter in men and more than 98 centimeter in the women. So higher the waist circumference, higher the incidence of CV because of central obesity. Skin fold thickness, and again, thickness does predict total body fat, but aids nothing more than BMI. It is again used, this tool is used in adult. Increased waist circumference measured from the top of the hip, and in children, it is defined as a more than 90th percentile for the age and sex. Fat distribution, obesity is classified into two types. One is a central obesity, that is android, and second is a gynecoid, that is lower body obesity, which is pear-shaped, and central obesity is the apple-shaped. And this is visceral fat, which is seen in the central obesity, which is associated with statistically higher risk of heart disease, hypertension, insulin resistance, diabetes, and symptoms of metabolic syndrome like abdominal obesity, increased hypertension, dyslipidemia, insulin resistance, increased CRP, and fibrinogen. So visceral fat is more dangerous and had more risk of these diseases and metabolic syndrome. So physical inactivity leads to significant increase in the visceral fat, independent of weight gain. And visceral, as we know that in Southeast Asian and Indian subcontinent, we have more visceral fat in around the abdomen and around the intra-abdominal area. And one more important thing is that low intensity exercise prevents visceral fat accumulation, but high intensity exercise is needed to reduce it. If you are doing simple walking, you are not able to reduce the visceral fat. You need a high intensity exercise. You can prevent the accumulation, but you cannot reduce it. If you want to reduce, just go for the high intensity exercise. Impact of obesity in children and adolescents. Obesity increases the risk of developing early puberty in children. It has a menstrual irregularities in adolescent girls, leads to the PCOD. Sleep disorders such as obstructive sleep apnea syndrome, cardiovascular risk factors, NAFLD, metabolic syndrome, they all are increased in obesity in the children and adolescents. Additionally, children and adolescents suffer from the psychological issues such as depression, anxiety, poor self-esteem, body image, and peer relationship and eating disorders. So these are the things which are commonly seen in children and adolescents with in obese children and adolescents. Now come to the why its obesity is increasing. What are the determinants in childhood obesity? The first and foremost is the lack of physical activity. Now the physical activity is very less. The children are doing very less because of the overindulgence in indoor leisure activity, like they are viewing more televisions, internet, and computer games, lack of the open space and playgrounds in schools and communities, increasing pressure in the children to perform in academics. Now the academics especially in Kota 9th class, they are living in the very pressure stage to perform in the various academic examinations. Reduced emphasis on sports contribute to the childhood obesity. Second is excess calorie intake. The unrestricted access to energy-dense foods at various platforms like school cafeterias, even hostel canteens. Here in hostels, at every hostel there are canteen, they are easily available. High calorie food and high fatty food are available 24 hours. Even in the mess also they are available in 24 hours. Low knowledge of about the dietary components in school children and increased calorie intake per body weight per day. So all these factors, now the calorie intake is increased and physical activities decreased. Some lifestyle related factors like daily allowance, like pocket money they are getting to purchase the outside food, and easy availability of domestic help to take care of the household chores, because everybody wants to have some helper, and they are doing all work and they are sitting and eating and viewing the TV. Commuting to school by bus or car instead of walking and bicycling, and aggressive advertisement by transactional fast food and cola companies. And whenever they are viewing the TV, almost 99% they are seeing all the advertisement of fast foods and colas and high calorie food. Increased liquid calorie consumption. According to the US FDA, the per capita soft drink consumption has increased by 500% over the past 50 years. And since 1978 to 1998, soft drink consumption was doubled in children between the age of 11 years and tripled in the teenager boys. What will ultimately leads to that study shows that 60% increased risk of the development of obesity in middle school children for every additional daily serving of sugar sweetened drinks. Just imagine a single serving drink had a 60% increased risk of obesity, and one serving per day, that is 150 calories in excess of the calories that your body needs, can lead to 6.8 kg weight gain in 1 year. Just imagine if you are eating 150 calories per day, that leads to 15 pounds or 6.8 kg increase in the weight gain. And that's 1 pound is equal to 3,500 calories, or you can say 1 kilogram is equal to 8,000 calories. If you are eating 8,000 calories extra, the 1 kilogram weight will be increased. So similar way, if you want to reduce your weight, you have to cut down the 8,000 calories. So just single serving have 6.8 kg weight gain in 1 year. Another factor is TV makes us fat. Average child and adolescent spend over 3 hours per day watching TV. playing video games, using the computers. For every 2 hours of TV watching, the risk of obesity increased by 23%, and the risk of type 2 diabetes increased by 14%. So just see the role of watching this TV and computers and this all other things. Almost 50% of TV commercial concern food, and 91% of which is rich in fat, sugar, salt, and none include the fruit and veggies. So all these factors are also equally important to prevalence and this obesity epidemic in our country. Each year, the average child sees about 40,000 commercial ads on television alone, and majority targeted at them are candy, sugar, cereals, and fast foods. Medical complications were already discussed by Dr. Keswani in the first slides. Obesity literally affects all the systems and all the organs in the body. But in children and adolescents, again, obesity have effect on the cardiovascular system, gastrointestinal system. In neurological, it has a pseudotumor cerebri. Respiratory system leads to sleep apnea and asthma. Endocrine system leads to diabetes and PCOD. Reproductive health system, again, menstrual irregularities in the adolescent girls. Orthopedics leads to the SCFE, renal glomerulonephritis and nephrotic syndrome. Dermatological, and one of the very important is psychological. Psychosocial, they are more, children are more feeling the depression, anxiety, poor self-esteem, poor body image, eating disorders, and sleep disturbances. They all are the comorbidities which are seen in the obesity, especially in children and adolescents. And link between obesity and type 2 diabetes, I think we'll discuss in the next lectures also, but one slide that we see type 2 diabetes in adulthood, but nowadays occurring in younger and younger age group, and obese people are more likely to develop type 2 diabetes. And this abdominal fat, this central obesity, cells releases pro-inflammatory chemicals, leads to insulin resistance. And one study was done and published in NEGM that 25% of obese children at the age of 4 to 10 years and 21% of children at between 11 to 14 years already had impaired glucose tolerance. So this pre-diabetes is significantly increased in the obese children, around 21 to 25%, which was published in NEGM 3 years back. This is a very popular slide. That is why paradox. Diabesity, the two brothers, obesity and diabetes, and because in more common in India, because we are thin and fat Indians. I think we know about the Professor Yagnik and Professor Yudkin, both are same height, weight, and BMI, but see the body fat. Professor Yagnik from Pune had a 21% body fat, and Professor Yudkin from Scotland, 9% body fat. So this is the ethnic difference. The Southeast Asian, we are prone for this disease. In Indian, patients are diagnosed at younger age, have less generalized obesity and thinner limbs, but have a higher central adiposity and are more insulin resistant than patients from the European and Caucasians. Another factor in children is cardiovascular effect. In children, increase in the incidence of hypertension, and it's seen in 20 to 30% of 5 to 11 years when BMI is more than 85th percentile. Similarly, hyperlipidemia is also more in obese children. Atherosclerotic lesions also seen in obese children at late adolescent age. So teenagers who are obese shown signs of artery damage that may increases the risk of heart attack and stroke later in the life, according to the study in the circulation. Psychological complication is already I discussed: low self-esteem, anxiety, depression, suicidal tendencies, eating disorders, poor body image, self-destructive behavior, risk-taking and teasing by the peers. They all are commonly seen in obese children. Cancer risk is more common in the adult, but also increased risk chances of cancer of all majority of organs like endometrial, ovarian, postmenopausal, renal, esophageal, gallbladder, colon cancer, but are mostly seen in the adult age group or elderly age group. So what we can do, how we can prevent or treat these conditions. So obesity intervention in children have 5, we are treated by dietary modifications, exercise, behavioral, medical, and surgical. dietary recommendations are the key factor. It starts from the infant feeding. The obesity treatment or prevention start from the infant feeding. Breastfeeding is protective against the childhood obesity, and it was studied that longer duration of breastfeeding associated with less obesity in childhood. Children breastfed for more than 12 months are less obese than children breastfed for only 2 months. This was study published in Circulation. Similarly, delay introduction of solid foods. Similarly, early introduction of solid foods before the age of 6 months corresponds to an increase the percentage of body fat by the age of 7 years. So this prevention of obesity or treatment of obesity start at the infant feeding stage at the age of neonatal age group. Dietary recommendation, we should start in the diet is the most important part for the treatment and prevention of obesity. That is, we should limit the portion size, try to eat less amount, avoid the saturated fat and trans fats that are associated with high risk of CV disease and type 2 diabetes. Increase the fruits and veggies in the food and diet, higher in fiber, and they are higher in water contents, and they promote satiety. So definitely help in the prevention of obesity. Family meals are very important. Try to have more family meals associated with higher quality diet and low obesity prevalence, and eating breakfast. Now, several studies has done that there is a positive association between skipping breakfast and increase in BMI in children. Exercise is another key factor in prevention and treatment of obesity. There should be at least 60 to 90 minutes exercise per day. They should be ideally done in the school. Now come to the medical treatment. Is already discussed. Drugs already discussed, but again I am going to say a few things about the children. And medical treatment, medicine recommended as an adjuvant to the therapy when BMI is more than 30 or BMI is between 27 to 30 with comorbid condition. The medication can lead to the 10% weight loss at best, and effects tend to level off after 6 months of use. Drug therapy, one of the commonly used drug is Orlistat, is the only FDA approved medication for the weight loss in the 12 to 18-year-old, but has unpleasant side effects. Metformin is also has been used in children with signs of insulin resistance, may have some impact on the weight, but is not recommended by the FDA. Other drugs, combination of phentermine and topiramate, FDA approved for weight loss in obese individual of 18 years and older, but not in children. About 99 to 10% weight loss over the age of 2 years. GLP-1 analogs is again used, have demonstrated great success in effective weight loss and approved by FDA for adult obesity, but not children. Orlistat is approved above the age of 12 years. It is a pancreatic lipase inhibitor, and it alters the fat digestion and inhibits the absorption of dietary fats, and its doses are 120 milligram before meal, twice or thrice in a day. And the side effects are include stomach cramps, diarrhea, and malabsorption, and fat-soluble vitamins. Metformin also produces weight loss in obese adolescents with insulin resistance and hyperinsulinemia, but it's not approved by FDA. Few other drugs, I'm not going in detail. Vitamin E, and also there are a lot of trials are going on with the tocopherol and tocotrienols in obesity. They have some effect on the obesity, metabolic and cardiovascular benefits, but it is not still approved. DHA, as a clinical trials done in obese pregnant mother using DHA, showed that mother who got DHA had children with lower adiposity at 2 and 4 years of age. Hydrogen technology is also nowadays tried in obese children. The hydrogen technology, which was shown to be effective towards weight loss in patients with metabolic syndrome, because hydrogen technology includes the fibers and high viscosity polysaccharides that absorb water in the stomach and increases the volume, thereby improving the satiety. Bariatric surgery is nowadays very very popularly used in grossly obese patients, and now it's also used in children also. Currently, the indication of bariatric surgery in adolescents are those who have BMI of more than 35 with at least one severe comorbidity, that is type 2 diabetes, severe obstructive sleep apnea, or pseudotumor cerebri, or severe steatohepatitis, or BMI of 40 or more with comorbidities like hypertension, hyperlipidemia, mild OSA, insulin resistance, glucose intolerance, or impaired quality of life due to weight. So nowadays, even bariatric surgeons are doing bariatric surgery in adolescents and children also with these indications. Before considering bariatric surgery, these patients must have completed most of their linear growth and participated in a structured weight loss program for 6 months, ideally, and a mental health provider is essential, as those with depression due to obesity or vice versa may have persistent mental need even after the weight loss surgery. There are 3 commonly used bariatric surgery. One is Roxanne-Y gastric bypass, laparoscopic sleeve gastrectomy, and gastric bending are the options available. Roxanne-Y gastric bypass and laparoscopic sleeve gastrectomy currently approved by FDA for children under the age of 18 years of age. At present, gastric bending is not approved by FDA, and compared to LSG and RYGB, has better outcome for excess weight loss and resolution of obesity-related comorbidities as shown in the studies and clinical trials. Overall, LSG is the safer choice and may be advocated for the more often in children. There are some risk factors also, risks associated with the bariatric surgery like infection, intestinal obstruction, vitamin deficiencies, gallstones, dumping syndrome, and sometimes there's a mortality of less than 1%. The key factor in the obesity in the children and adolescent is the prevention. The main mantra is the prevention that start from the intrauterine life, pregnancy to postpartum age group, and the family atmosphere at schools, at community level, at healthcare provider level, at industry level, and government and regulation agencies. So all these are levels where we have to work together. Otherwise, the way the obesity is increasing in our country, it is very difficult to prevent. And these are the few general measures of prevention of obesity are that child must have the regular meals, including the breakfast, number 1. There are 45 to 60 minutes of regular, moderate to vigorous physical activity in either school or nearby playgrounds. The screen time should be restricted to 1 hour or below 1 hour daily. Avoidance of snacking, inactivity, and screen exposure while eating. Avoid rigorous dieting. Identify red flag signs for psychosocial impact like school absenteeism, body shaming, or teasing by peers regarding weight and appearance, persistent anxiety, depression or self-esteem, anger, substance abuse, eating disorders, and family stressors. Specialist referral if presence of complication. One of the very important thing in the prevention of obesity, which was given by the American Academy of Pediatrics, that is 5-2-1-0 rule. So let's go for this rule, and should be applied in every family and every school and everywhere. That is 5-2-1-0 rule. And for healthy lifestyle, this is recommended by American Academy of Pediatrics, and that refers to eat 5 servings of fruits and vegetables daily, view less than 2 hours of screen time, participate in 1 hour of physical activity, and consume 0 sugar sweetener beverages daily. So if you apply this rule since childhood, since in a family, definitely you can prevent the obesity in future. Other also like ensure the adequate sleep also. Similarly, ensure the intake of nutritious food rather than high calorie and carbohydrate and fatty food. Now, role of the parents and family is also very important for prevention and treatment of obesity. Parents and family play a crucial role in preventing childhood and adolescent obesity in India. Here are some ways in which parents and family can help, like encouraging the healthy eating, limit the screen time for less than 1 hour, promote the physical activity at least 1 to 2 hours per day. Be a good role model. Otherwise, you cannot guide your children, and avoid rewarding with the food and seek the medical help if any problem occurs. So overall, parents and family members have a significant role to play in providing childhood and adolescent obesity in India by promoting healthy eating habits, limited screen time, encouraging physical activity, being a good role model, avoiding rewarding with the food, and seeking medical help when needed. Parents and family members can help their children maintain a healthy weight and promote a healthy life. The Government of India also launched various projects like Poshan Abhiyan, National Program for Prevention and Control of Cancer, Diabetes and Cardiovascular Disease and Stroke, School Health Program, Rashtriya Bal Swasthya Karyakram, Eat Right India. This is one of the very good programs running in India. These programs focus on the promoting healthy eating habits, physical activity, and early detection and management of obesity and other non-communicable disease. Eat Right program, the Eat Right program, India program is initiative launched by Food Safety and Standard Authority in 2018, that is 5 years ago. The aim of program is to promote healthy eating habits and reduce the prevalence of obesity and other diet-related diseases in India. The program is based on 4 key pillars: that eat safe, eat healthy, eat sustainable, and food fortification. So finally, obesity is a real challenge in young and adolescent population due to modernized lifestyle. Modernized lifestyle. Timely diagnosis and awareness play a key role in the obesity management and promoting healthy life. Childhood obesity is a ticking time bomb that has serious health, social, and economical consequences. It is a complex problem that requires a comprehensive and sustained effort to prevent and address. Preventing childhood obesity requires a multifaceted approach. This includes educating parents and children about healthy eating, exercise habits, promoting physical activity in schools and community, and creating policies that support healthy food environment. So finally, be working together, we can definitely prevent and with the best possible chance of reaching their full potential. Thank you very much. Thanks for hearing, and thanks for everyone. Thanks.
Thank you, Dr. Ramchandani, for your nice, very informative talk. It is the children which are the important part of our society, which will take us towards tomorrow and whole of the world in the future for much better atmosphere. And if our children are affected with the obesity, you have rightly mentioned that it is a ticking time bomb. If they are not healthy, they are going to develop diabetes, cardiovascular diseases, and so many other diseases. And we have to take care of this. And very good information you have given regarding the prevention and controlling obesity in the children right from the antenatal period and later on, depending on the diet and reducing the cola and the sweet beverages. And it was a very informative talk, and hope we all will utilize your words in our practice, and we can also make some charts which we can which we can put in our clinics, so that our patients also become aware that we have to keep our children fit and away from the obesity. If there are any questions, you please don't hesitate to talk. And we can see a number of compliments to Dr. Ramchandani and Dr. Rajeev by Dr. Ashutosh, Dr. K.K. Sharma, Dr. Gaganunjan, Nitin, and Venugopal for your nice, informative lectures. Thank you, Dr. Ramchandani, for your nice lecture. And next time we will have 2 important speakers with us who will be giving their talks about relation of obesity to diabetes and to the cardiovascular diseases. And my request is to all the participants to please send your names and city to us so that we can start making your certificates of participations, so that by the end of the program only, you will get those certificates. Thank you, Dr. Ramchandani. Thank you, all the participants.
Thank you, sir. Thank you for your dedicated efforts to encourage all the physicians of the country. The dream of Dr. K.K. Parikh, sir, that to reach out to the smaller part of the country, and the topic is also very important. And you designed the topic in such a wonderful way that all the things are covered, and the speakers are also very excellent. And just say the present and the participation is also, I think it is more than 100, and still the students are coming for
Yes.
requesting for registration. So that's all credit goes to you, Dr. Keswani, sir. You are dedicatedly.
Not to me, because the speakers are also equally good and topics are also good, and it's a teamwork, and success goes for the participants only. If they participate in a good number, then everything's get happy that things are going well. So it is the contribution of all the participants and all the speakers, and of course our organizing team, Dr. Parikh sir, Dr. Mathur sir, and Dr. Jyotirmay Paul. Thank you all the participants, and as there are no other questions, we will be meeting on the 28th of the May, same time at 2:30 p.m. And you all please send your names and the name of the city so that we will start making your certificate of participating. Thank you. Bye-bye. See you again on 28th May.
Thank you, sir. Thank you very much.
Thank you. Thank you. Thank you.